last presentation of the session. These are my disclosures. I wanted to first state that I'm presenting this data on behalf of Dr. Lindsay Roker from MSK, who was unable to be here today, and in addition, on behalf of colleagues from 15 academic centers and 51 community sites that contributed this data. These are my disclosures. So the title of our topic today is Predicting Tumor Lysis Syndrome in venetoclax-treated CLL Patients. The objectives of the study were to describe the rates of TLS observed in clinical practice, and then to try to understand what additional factors besides the standard risk criteria such as ALC or bulk of disease by lymph node size could contribute to us understanding risk of developing tumor lysis syndrome. This was a multi-center, retrospective cohort study of 339 CLL patients who were treated with venetoclax. We collected baseline demographics, baseline genetic characteristics. We collected TLS risk as well as prophylaxis, and then the occurrence of TLS, and we asked investigators to assess TLS by standard Howard criteria. We then tried to test the association between TLS and proposed risk factors in addition to the standard criteria, and performed univariate and multivariable analyses with a plan to calculate the area under the ROC curve for independent predictors. Our cohort included 339 patients. The median age was 67. As you can see, the median number of prior therapies was 3. 78% of patients received prior ibrutinib. This cohort was largely a clinical practice cohort. Only 13% of patients received venetoclax in the context of a clinical trial, and 79% of patients received venetoclax as monotherapy. 94% of patients received venetoclax in the relapse refractory setting. In terms of TLS risk stratification, the patients are fairly evenly divided. About a third of patients are low, intermediate, and high risk. 45% of patients had a creatinine clearance estimated at less than 80 milliliters per minute. And importantly, 94% of patients had CT imaging performed prior to the start of venetoclax to inform TLS risk. In terms of prophylaxis strategies, as you can see, most patients received appropriate management. 93% received allopurinol prophylaxis. 43% received respiricase prophylaxis, 87% normal saline. The median number of planned hospitalizations during the ramp-up was 2, with a range between 0 and 5. Interestingly, although two-thirds of the patients were low and intermediate risk, 75% had one or more planned hospitalization for monitoring and prophylaxis during the ramp-up period. In terms of the endpoint of interest, or the clinical endpoint of interest, TLS, the overall rate of TLS in this cohort was 10%, 35 cases out of 339 patients. 26 cases were laboratory TLS, 9 cases were clinical TLS. In terms of our analysis, we first performed univariable analyses on various factors including sex, creatinine clearance, complex karyotype, deletion 17p, IGHV status, prior ibrutinib exposure, venetoclax administration, whether it was given as a monotherapy or in combination, and then standard risk categories. We found that creatinine clearance and complex karyotype were predictive of the development of tumor lysis syndrome with an odds ratio of 2.9 and an odds ratio of 2.2, as well as standard risk criteria, including high versus low stratification with an odds ratio of 4.2 and high as compared to low and medium risk with an odds ratio of 2.6. We then took significant predictors from our univariable analysis and included them in a multivariable logistic regression. Here we found that TLS risk high as compared to low or medium was an independent predictor of the development of tumor lysis syndrome, as well as creatinine clearance. The odds ratios were 5.87 and 2.53. Of note, complex karyotype was not significant here. The odds ratio was 2.36 with a p-value of 0.05. We then calculated the area under the ROC curve of the multivariate model, which included TLS risk as defined by low versus high or medium and creatinine clearance, and the area under the curve was 74.6%. Of note, the area for the model, which included only standard TLS risk, was 65%. So in conclusion, renal function does appear to matter. Patients with impaired renal function, and here it's estimated as a creatinine clearance of less than 80, are at an increased risk for developing tumor lysis syndrome independent of tumor burden. We felt that further study of creatinine clearance as a continuous variable to help refine risk is warranted and should be included in further study and the development of future models to predict tumor lysis syndrome. Also, practitioners should consider modifying prophylaxis and monitoring strategies based on renal function. And while complex karyotype was not significant in this particular study, it's worthy of further study in future models and larger sample sizes. Thank you very much.